Thanks for everyone to sparing their time uh, uh, on a busy day. So we will discuss in this time regarding the sequencing in metastatic prostate cancer, which we hardly discuss in day-to-day practice. These are finer details. They require a finer look to understand how best we can sequence these agents to get maximum results.
So, uh,
Yeah. So this is a very famous slide. Any prostate cancer, if we see, we always begin prostate cancer with a non-metastatic disease, which is hormone sensitive, or what we call as castrate sensitive. And as the disease progresses, it becomes castrate resistant. And you can see so many drugs being there right from the castrate sensitive setting, right from docetaxel, and then we have enzalutamide, abiraterone, radium, Superspeciality. So, and then we have the castrate resistant setting. So, any metastatic prostate cancer will have an initial, I can say, 2/3 of their life with a hormone sensitive setting, and then the rest 1/3 of their life in the castrate resistant setting. So, we have all the drugs approved both in the sensitive situation and also in the resistant situation. So, so with this in background, so we have every drug everywhere. So how to put drug where, and are there any take-home messages we can take by the end of the day? For example, if you take a if you take a non in a metastatic setting, hormone sensitive setting, we have docetaxel, we have enzalutamide, we have abiraterone, and of course ADT is there right from beginning up till the ending. So which one to use first, which one to use next? So should I use docetaxel first, or abiraterone first, or enzalutamide first, or should I keep it reserved in the CRPC setting? Suppose if it is the CRPC, which one to be used for? So this sequencing needs little finer knowledge, and these clinical trials individually will not address this issue. We have to look into the overall picture of the clinical trials and look into their selection criteria and then understand. So this is the famous docetaxel trial, the TAX 327 trial, which made docetaxel in the castrate-resistant prostate cancer to be the standard of care. So before we had only the androgen deprivation therapy being the standard of care in prostate cancer, and then we had mitoxantrone, which improved the quality of life of patients. And then we had docetaxel challenging mitoxantrone as far as improvement. You can look into the endpoints of this. It is improvement in pain, response in terms of pain improvement, serum PSA level improvement, and quality of life. So these are the endpoints this TAX 327 had, and you can see the three arms, the 75 milligram per meter square, 30 milligram per meter square, and mitoxantrone. So the endpoint was not survival, it was basically quality of life, which makes more sense because that is what we are looking into, a castrate resistant prostate cancer as well. So if you finally look into the 3 weekly and the weekly docetaxel regimen, you can see the response rates are almost equivalent in the two arms, whereas when it comes to the hazard ratio, it's quite impressive with the 3 weekly arm. So this made docetaxel to be the standard of care in a castrate-resistant prostate cancer, and the comparator arm was mitoxantrone, and the endpoints were responses in terms of pain, PSA level, and quality of life, and it was not a PFS or overall survival. So then, post docetaxel, we have all these drugs being approved in the CRPC setting. We have cabazitaxel, which is the TROPIC trial that said that those patients who progress on docetaxel respond to cabazitaxel, which was a positive trial. You can see the hazard ratio of 0.72 and the overall survival 15.1 versus 12.7 months. And then we had enzalutamide in the affirm trial, where even this also showed an overall survival benefit. And then we have abiraterone, and then we have radium in the Alsimca trial. Even this also had a good hazard ratio. You can see all the four drugs have a good hazard ratio and have shown improvement in overall survival post docetaxel CRPC setting. So then, pre-docetaxel, we have the PREVAIL study and the COU AA302 study, where both enzalutamide and abiraterone have shown improvement in overall survival. You can see the hazard ratio of around 0.7 again. So, we initially had docetaxel in the CRPC that was compared against mitoxantrone that improved overall survival, and then we had all the four agents post docetaxel. Pre-docetaxel CRPC setting, we had abiraterone and enzalutamide also showing overall survival benefit. So, what is the algorithm for sequencing in a metastatic castrate-resistant prostate cancer? Which drug to choose? So, it is very difficult to say because each trial is addressed with a question that whether this, for example, if we take the pre-docetaxel CRPC, the trial is just meant to address whether abiraterone works in the CRPC pre-docetaxel or not. It is not compared with enzalutamide. Similarly, in the post-docetaxel era, in the post-docetaxel setting, all the four options are not compared head to head. So it is very difficult to come to a conclusion which drug is superior or inferior and which one to choose first. So with these difficulties, if you look into the sequencing, all these play a role regarding the PSA doubling time, LDH, alkaline phosphatase, and the clinical parameters, whether symptomatic or not. What is the volume of disease and other parameters as well. So based on level 1 evidence and adverse events, performance status, symptomatic disease, comorbidities, and retrospective phase 2 results, time to CRPC, prior therapy, exposure response, tumor characteristics, all these factors influence outcomes. So this is one important thing that we need to understand. So we all know that metastatic prostate cancer basically is sensitive to hormone deprivation or androgen deprivation. So mind you, if the androgen deprivation duration is less than 1 year, that means the androgen sensitivity is less. So in those settings, so supposing we have a metastatic prostate cancer and we have started androgen deprivation therapy either by bilateral orchidectomy or by medical castration. If the progression-free interval is less than 1 year, that means this is sort of a hormone-resistant disease. It's a hormone-resistant CRPC because within a 1 year, if it is progressing, it is very unlikely that further hormonal agents are going to act. Therefore, before using enzalutamide or abiraterone in this setting, we always have to see what is the duration of androgen sensitiveness that the patient has been on. If it is less than 1 year, it is unlikely that further endocrine therapies will help in this patient. So if you have a CRPC patient, we always have to look into what is the duration of androgen deprivation. If the duration is more than 1 year, or even if it is better if it is 1.5 years, 16 months is what has been there, only then we can subject them to hormonal therapies. Otherwise, it's a fast multiplying disease which is unlikely to respond to endocrine therapy. On that occasion, docetaxel will be a better choice. So this is one take-home message which we can have. So whenever we have a CRPC, we always have to see what is the duration of androgen deprivation therapy the patient was on from the metastatic setting, whether it is less than 1 year or more than 1 year. If it is less than 1 year, straight chemotherapy. If it is more than 1 year, better if it is 16 months, then we can expose them to hormonal therapies like abiraterone or enzalutamide. So these are the limitations we have. Overall survival since the initiation of docetaxel never reported So multiple, we have shorter follow up and the contrasting results and small sample size, post hoc analysis. So these all limit the reporting of trials and coming to a conclusion. So, however, we can draw few conclusions based on the existing trials. So, few conclusions what we can draw are enzalutamide. Basically, overall survival is in favor of enzalutamide, both in we are speaking of CRPC setting over here, both in chemotherapy pre-treated and in naive pre-docetaxel and also post-docetaxel. The overall survival, if you take as an endpoint, enzalutamide has a better hazard ratio. Then overall survival is identical in patients with visceral disease and more than 75 years. And overall survival relatively non-significant, better with enzalutamide in patients without visceral disease. So what we can understand from this is if you have a visceral disease, basically, even in the with abiraterone. So if you have a bone-only disease or a limited disease in the CRPC setting, yes, overall survival benefit is there, but when it comes to visceral disease, enzalutamide is less efficacious. So this is one we can understand. So in the hormone-sensitive setting also, if you look into this visceral disease, enzalutamide has a problem. Bone-only disease, slowly proliferating disease, longer androgen deprivation therapy time. When all these are there, enzalutamide does better. So enzalutamide we must choose when a patient is on a longer duration of ADT, or we think he is still androgen deprivation sensitive, has a lower Gleason's or a lower grade disease, less visceral disease, limited disease. So in this subgroup of patients, enzalutamide does well when compared to a high grade multiple visceral disease or a short time of androgen deprivation. So we have to choose enzalutamide. It's more of a hormonal therapy. It doesn't inhibit the adrenal androgen synthesis. So we have to choose enzalutamide in a more of a benign disease, which is of a lower grade, than in a visceral disease or a high disease burden. So these are all not clear-cut conclusions. These are all things which we can analyze when we look into multiple trials and their results. So these are again, you can see multiple trials reporting what if I use abiraterone first and then after docetaxel and enzalutamide, what if I use enzalutamide first. So again, contrasting results. So what if, so we have understood one thing, that we can, in the hormone sensitive setting also, it is not enough if we give androgen deprivation therapy, we have to add systemic therapy. So to answer this question, what about earlier chemotherapy? So what if we start having patients that have already received chemotherapy and have hormone sensitivity? So things are changing, since they may have to go directly to second line chemotherapy with cabazitaxel when disease progresses, or try a re-challenge with docetaxel. So nowadays, in the hormone sensitive setting, we are not confined only to androgen deprivation therapy. Along with androgen deprivation therapy, we also use systemic therapy. Systemic therapy can be docetaxel, or it can be abiraterone or enzalutamide. Supposing if we have used docetaxel in the androgen in the hormone sensitive setting, should we re-challenge docetaxel in the later setting, or we should give cabazitaxel? So this is one question that we need to understand. So survival after first line docetaxel treatment for CRPC in patients who received docetaxel in the hormone sensitive setting, we can see if you expose docetaxel in docetaxel pre-treated patients, you can see the median overall survival is 27.5 versus 23 months, and it is different. And then there are more considerations. So we have to look into the volume of disease, PSA decline, and all these. And one thing we are sure, that the disease burden in patients who have a higher disease burden, for example, there are more than 3 bone metastases, or if there is visceral disease, So on those versus those patients who have a low disease burden, you can see the difference in overall survival. It is nearly 4.5 year difference in survival. So all metastatic prostate cancer patients are not the same. Those who have a high disease burden survive for 3 years, and those who have a low disease burden, have a benign sort of a progression, have a longer survival. So there is definitely difference in survival as far as the volume of disease is concerned. So you can see one more meta-analysis saying that MRI was better than PET-CT or bone scan as far as picking up the burden of disease is concerned. And is PFS a surrogate for overall survival in trials? So two trials, both Chartered and Stampede, have said yes, whereas GETAG, there is no translation of PFS to overall survival. So what is the impact of prior response to abiraterone on docetaxel efficacy? Basically, whether the patient received abiraterone before or not in the hormone sensitive setting or in the CRPC setting, the docetaxel efficacy is not altered. So PSA response rates were not linked to prior response to abiraterone. So we can use docetaxel irrespective of whether endocrine therapy was used before or not. So then, because enzalutamide was an expensive molecule before, we also used to use enzalutamide when we had exhausted all treatment options. So this is one of the retrospective study of 47 patients, where all patients were treated with docetaxel and abiraterone. They had complete androgen blockade, and 79% had bone mets, 55 had lymph node mets, and 17% had visceral disease. So the median duration of enzalutamide treatment was up to 3 months. So very short duration is what, and the overall survival was 40 weeks. So, and the PFS was just 3 months. So, and the median time to PSA progression was 15.7 weeks. So enzalutamide was well tolerated, and there was 23% response rates in patients of CRPC who were heavily pretreated. So even when you use enzalutamide in heavily pretreated patients, you expect a we expect a response rate of around 20% and a PSA PFS of around 3 months. So this is what we can expect. So one thing what we can see is if you give first abiraterone and then enzalutamide, you have a better PFS than the other way. So when we are sequencing, it is always better to give abiraterone first and then enzalutamide rather than enzalutamide first and then abiraterone. So this has some soft indicators that we can use. So we always remember in the alphabetical order. So A first and then E. So if you give abiraterone first and then enzalutamide, you have some improvement in PFS than E followed by A. So these are all retrospective data with which we can infer. There are no randomized trials to address these issues. So if I am using abiraterone first and then enzalutamide, then the chance of responses at PFS is better. So then coming on to the resistance mechanisms, there are multiple normograms that have come up, whether they're going to be resistant or not. None of them have been that successful, but if there is primary androgen resistance, if you use abiraterone, 1 out of 3 patients will respond, whereas in enzalutamide, 1 out of 4 will respond. So then as second line therapy in metastatic CRPC, PSA responses for cabazitaxel post docetaxel are quite similar pre or post abiraterone. So basically these hormone therapies have got nothing to do with cabazitaxel. So when you take cabazitaxel or docetaxel, they have got nothing to do with hormonal therapy. Whether they have taken enzalutamide before or abiraterone before, it doesn't matter for them at all, because they're basically dealing with a resistant population or a hormone resistant population. So this is the clinical outcome of taxane treatment versus AR treatment as per ARV7 status. Basically, ARV7 is a mutation in the androgen receptor level. So if you have a ARV7 mutation, then endocrine therapy basically doesn't work. So if you have, so ARV7 mutation may be there primarily where we call as primary androgen resistant, or it can develop over a period of time, or it can be acquired also. So So if a patient has a primary endocrine resistance, on those occasions we have to check whether it is a ARV7 mutant population, or over a period of time, when there is acquired resistance to androgens, again we can have ARV7 mutation being present. So basically, when there is ARV7 mutation, then endocrine therapy won't work. We have to choose taxane chemotherapy over endocrine therapy. This is what we can understand from ARV7. So again, the same thing is what we are saying. The ARV7 negative. So initially it was ARV7 negative, later also ARV7 negative. On that occasion, androgen endocrine therapies do better. You can see the PSA PFS of 6.1 months. The moment mutation, then the PSA PFS comes down to 3 months. Whereas if it is primarily endocrine resistant, ARV7 mutation is there right from the beginning, then the PSA PFS is 1.4 months. So it is 1.4 versus 3 versus 6 months, depending on whether it is primarily ARV7 mutant versus acquired ARV7 resistant mutation versus ARV7 negative population. So again, if there is ARV7 mutation, definitely the way to go is taxanes. So compared with 62 patients previous trial, ARV7 mutation meant taxanes appeared to be more efficacious than enzalutamide or abiraterone. So this is what it is. So whenever we have a primary endocrine resistant, or we have acquired resistance, then the choice should be a chemotherapy rather than a hormonal therapy. So again, this is another slide saying that in pre-docetaxel use patients, if you have ARV7, then cabazitaxel is the way to go rather than giving them hormonal therapy. So again, ARV7s can also be detected in circulating tumor cells. However, it is not yet validated in the liquid biopsy as of now. So in ARV7 positive men, again taxanes are the way to go, and not the androgen deprivation or the endocrine therapies. So these are the liquid biopsies which are there, with which we can detect ARV7 mutation in circulating tumor cells. And then beyond that, now what we are looking in prostate cancer is basically the underlying DNA repair mechanisms. So for example, the BRCA1 mutation or the ATM or the CHEK2 mutation, so which are basically familial or may have a Mendelian sort of a inheritance. So we always look into the presence of a BRCA1 mutation or a BRCA mutation in a prostate cancer. So if that is so, olaparib and platinum have got some role in this set of population. So this is some data on using platinum in those patients who BRCA mutant. You can see the median progression-free survival is around 9.8 months, the radiological PFS versus 2.7 if you use platinum. So there is some role of platinum if there is a BRCA mutation is present. Again, platinum-based therapy plus oral cyclophosphamide is a tolerable, promising regimen for heavily pretreated poor PS metastatic CRPC if they have anaplastic features and morphology. So again, carboplatin plus cabazitaxel with GSF was also used. That also showed. So basically, in an aggressive variant or an anaplastic variant, we can use platinum. So in neuroendocrine variety, we always had a thought that we should use platinum. However, these two trials have said that they are quite toxic and the responses are modest. So there is another data coming up. If there is abiraterone resistance, we can change the prednisolone backbone to dexamethasone backbone, or the other way is abiraterone withdrawal also reduces resistance. So these are the ways by which we can look into the DNA repair mechanism. So basically, what happens in a BRCA mutation is basically the DNA repair is what is defective. So normally, whenever there is a double-stranded DNA damage during cell multiplication, it is repaired by the BRCA. So basically, BRCA gene when it is deficient, this double-stranded DNA repair doesn't happen. So when the double-stranded DNA is not repaired in a BRCA mutation, these PARP enzymes are the ones that repair the single strands. So they half repair the double-stranded DNA break. So when these PARP enzymes are there, they do some half repairing of these defective cells, and these defective cells continue to multiply. So if there is BRCA mutation, this double-stranded DNA breakage is which is there, it is not repaired. So but these PARP enzymes come over and they do some repair which is enough for sustaining survival. But these are defective cells, and they go ahead with malignant proliferation. So what we do is synthetic lethality is basically we inhibit these PARP enzymes which half repair so that the cell goes into apoptosis. So this is the mechanism how olaparib acts, where it prevents the activity of PARP enzyme and doesn't allow these cells which have a double-stranded DNA break to propagate further. So this is what we call as synthetic lethality. So then, hormone sensitive setting, we have both abiraterone and docetaxel. Both have shown overall survival, both in started trial. So what we can understand is in the this docetaxel basically doesn't work well in the low volume disease, whereas in the high volume disease, docetaxel has shown survival benefit. So you can see the significance of p-value of 0.0006 in high volume disease versus low volume disease. So in the hormone sensitive setting, if there is a high volume disease, docetaxel is the way to go, and not in the low volume disease. So, however, some meta-analysis also have shown that volume of disease doesn't matter. We can offer docetaxel irrespective volume, but however, in practice, we reserve docetaxel to those patients who have high volume disease in the hormone-sensitive population. Again, Stampede trial also has shown abiraterone to be effective in the hormone-sensitive setting, and we can see all the subgroups in which it has been effective. Again, the Latitude study also has shown that abiraterone plus prednisolone is effective in the hormone-sensitive subgroup. So what may come next for treating hormone-sensitive prostate cancer patients is in hormone-naive prostate cancer, abiraterone plus prednisolone improves overall survival and failure-free survival only when it meets at least 2 of the 3 high-risk criteria, mainly if Gleason's is more than 8, presence of more than or equal to 3 bone lesions, or presence of measurable visceral lesion. So who is the early chemo candidate patient? Maybe when we have the clinical presentation of a more aggressive disease, such as multiple visceral lesions or rapidly progressive in restaging before any treatment in hormone-naive patients. So, but however, these data are very soft and not clear. So, we reserve docetaxel for high volume disease and high Gleason's, visceral mets. So, what we can have for take-home messages today is, number one, whenever we see a CRPC, we always have to see what was the duration of androgen deprivation therapy. If the duration of androgen deprivation therapy was less than 1 year, then the only way to go is chemotherapy, that is taxanes. This is one. So we have to look into the pace of disease, and then we have to use medications in the CRPC setting. So if you have an androgen deprivation therapy duration of less than 1 year, then chemo is the way to go. And secondly, if you are using sequencing, whether it is first abiraterone, then enzalutamide in the CRPC setting. So if at all, if we are using 2 endocrine therapies sequentially, then the way to go is to use first abiraterone and then use enzalutamide. Third take-home message is, if you look into overall survival, enzalutamide has shown impressive overall survival only if it is a low volume disease, bone only mets, low grade disease. Whereas in visceral disease, either in the mainly in the HSPC setting, however, even in the CRPC setting, there is some indication that enzalutamide may not be that effective if there is frank visceral metastasis. So if you have bone only mets, low grade disease, then enzalutamide is the way to go. So then fourthly, if a patient has progressed on docetaxel within 6 months again, in the CRPC setting or in the HSPC setting, within 6 months progression, then it is a high grade disease, then there is no point exposing these patients to hormonotherapy. So we have to use cabazitaxel in the subsequent line. And then to add further, so along with this, we also have to look into other biomarkers like BRCA mutations, preferably somatic BRCA, looking into BRCA mutation in the tissue. If it is present, then olaparib or platinum also has shown some impressive results. So in the neuroendocrine setting, how much etoposide platinum does benefit? It's toxic. It has got modest responses. Whereas in the anaplastic setting, we have some data of taxane platinum combination of platinum doing little better. So, and then if you have a MSI high population, immunotherapy is the way to go. So with these few concluding remarks and some take-home messages, which are difficult to obtain from clinical trials, I would like to conclude my presentation and hand over back to the organizers. And I would thank everyone for their patient listening. Thank you.